Good morning, good afternoon. So today we'll talk about care of patient undergoing radiotherapy. So the objectives of the today's sessions are, at the end of the session, the students will be able to define radiotherapy, explain about the historical aspects, explain the effects of radiation therapy, the types of electromagnetic rays, the uses of radiation therapy, and list the types of radiotherapy, identify the side effects, and discuss about radiation protection, and then we'll discuss about the nursing management of the patient undergoing radiotherapy. So to simplify the topic, I've divided the radiotherapy into four sections I've divided. So in the first section we'll talk about the basic concepts, which will include the definition, the history, radiation physics, the radiobiology, the different sources of radiation, principles, that is the 4 R's of radiation, which includes repair, reoxygenation, repopulation, and redistribution. And then we'll talk about radio-sensitivity. So in this, we'll talk about the basic concepts. And in the second section, we'll talk about the radiation treatment planning, the actual process of how the radiation process is being planned. In the third section, we'll discuss about the side effects, its management, and the nursing management of the side effects. In the fourth section, then we'll talk about the radiation safety aspects, how the radiation unit should be designed, the room shielding should be done, if there's any accidental exposure, what should be done. So let's go about the seminar. So radiation therapy. So it is ionizing radiation is used to interrupt the cellular growth. Radiation therapy, it is a localized treatment that is used alone or in conjunction with other treatments such as surgery or chemotherapy or both. So talking about the history, so in 1895, Dr. Roentgen discovered X-ray, which was a major help in radiation therapy, which led to birth of radiation therapy. And then in 1896, Dr. Becquerel discovered radioactivity, and which was followed by discovery of radium by Perry and Marie Curie in 1898. So in 1898, the first successful radiation treatment was done. It was basically, when it was first initiated, it was basically used to treat the skin cancer most frequently. In 1920 to 1940, studies were conducted to evaluate the effects of radiation on tissues, and fractionation of the tools was started. Then the first treatment was done using cobalt machines, and Linacs came, that is linear accelerator, then multi-leaf collimators came. So then also, as I told you, that the radioactivity was discovered, radioactive substances were discovered. So in the World War II, when the radioactive substances were used to kill many people, like it was used in Hiroshima and Nagasaki attack, and at the same time, so in radiotherapy, the same thing was used so like we were using the radioactive substances in the world wars, and then in radiotherapy we used it against in a war against cancer. So okay, then with the advancement of technology, the radiation therapy was improved. So this is the early 1950s radiotherapy machines, and this is how it is today. We are having with the better technologies. So coming to the radiation physics, so radiation therapy is actually a applied form of physics in the use of cancer treatment. The use of ionizing radiation to interact with the atoms and molecules of the tumor to produce specific harmful biological effects. Electromagnetic spectrum. So we have an electromagnetic spectrum, which is any type of radiant energy in the motion or wave or particulate characteristics that has capacity to impart some or all of its energy to the medium through which it passes. So we are all surrounded by different type of electromagnetic spectrum. As we know, we have radio waves, microwaves, infrared waves. We may not even be able to see the waves, but these are all present here. So, and then we have visible light, UV rays, X-rays, and gamma rays. So the type of rays that are used in radiation therapy are the ones with the higher ionizing with a higher frequency. So we have X-rays, gamma rays, which are used. So radiation, which is actually divided into two types. We have non-ionizing radiation and we have ionizing radiation. Ionizing radiation is the one that we are using in radiotherapy. It is direct, and then we have the two types, which is directly ionizing, which includes electron, protons, and alpha particles, and then indirectly ionizing, which are photons, which are X-rays, gamma rays, and neutrons. So So the type of radiation therapy, radiotherapy is based on the use of two main type of radiations. We have electromagnetic wave, which consists of X-rays and gamma rays, and we have particulate waves, which includes electrons, protons, and neutrons. So when we talk about the basic structural, the smallest structural and functional unit we say in biology is a cell, whereas when we talk in the chemical and physical aspects, we have the basic structural and functional unit as an atom. So what is an atom consist of? An atom is consist of protons, neutrons, and electrons. Then we have in the nucleus, we have protons and neutrons, which are surrounded by electrons, which are surrounding in our orbits. Okay, so this is a structure of atom, and in a stable atom there will be electrons surrounding, and there is no release of the electrons. If there is any release of electrons, protons, or neutrons, then the atom will be called as unstable, and which is actually used in the unstable atom, which is used actually in the radiation therapy. Okay, so that is it. Then radioactivity is another concept in the radiation physics. So it is a process by which an unstable nucleus decays into new configuration that may be stable or unstable, and the decay can be in the form of electromagnetic radiation or kinetic energy, which is both used in the radiation therapy. And the common examples of radioactive substances used are cobalt and iridium. Okay, so then we have another concept of half-life. So in radioactivity, when we are using a radioactive substance, so we have a substance which is actually emitting the radiation. So we have half-life, concept of half-life. So it is a time during which the number of radioactive parent nuclei decays from the initial value to half the initial value. So what happens in why this concept is important? Because if we are using a radioactive substance, so we want to know when the radioactive substance will be decaying, so that we need to replace the radioactive substance. Then the different sources of radiation are, we have natural, which is radium, cobalt, iridium, scantium, and palladium, and then different isotopes of these atoms. Then we have man-made, which is LINAC. So LINAC is actually a linear accelerator. It is a type of particle accelerator that accelerates the charged subatomic particles or ions to a high speed by subjecting them to a series of oscillating electrical potentials. So they allow the electrons to collide with heavy metal targets, and then with this way they produce high energy X-rays. Okay, so this is a type of machines which are used. This is the brachytherapy machine that we are using. So this in this we have a radioactive substance containing inside, and then the small pores in the front that you can see in this. With this we connect with the applicators, and then we give the radiation therapy to the patient. This is the LINAC, which is a linear accelerator, as I told you. So this actually produces the linear X-rays. Okay, then this is a simple linear accelerator, and then this is the one which is along with the CT machine, so that we can actually see align with the patient's tumor site. So radiobiology, then we talked about the radiation physics, how the physics is applying into the radiation therapy. Now we'll talk about the biological effects. The biological effects of the radiation on humans are a result of sequence of events that follow the absorption of energy from ionizing radiation and the organism's attempt to compensate for this assault. So we have two types of effects. So according to target theory, we have two types of effect. We have a direct effect, and then we have indirect effect. So it interacts with the cellular medium producing free radicals, which is an indirect effect, or it can affect via molecules are damaged by the energy, which is a direct effect. So as a result of this, there will be damage of DNA, and which will result into cell death or delayed mitosis. Okay, so this is how it happens. So there will be break. There can be double-stranded break, there can be damaged base, there can be single-streak break, there can be intra-strand cross break, there can be inter-strand cross-link break. Okay, so then effects of radiation on the cell. So it is affecting in many ways. So in physical, it results in ionizing. Chemical effects, it results in breaking of atoms or molecule bonds or chemical changes. Biological, there's change in chemistry of the molecule. And clinical, there will be tumor regression, cancer induction, and tissue fibrosis. So the question is, it is affecting the cell. We did not talk about the tumor cell or it is a normal cell. So what is, if it is killing the tumor cells, so it must be affecting the normal cells as well. So what is happening to normal cell? The question is that. So they are also affecting the normal cells, but they are capable of repairing themselves. As we know, the tumor cells, they are having some genetic mutations, which is the reason why they are not able to undergo apoptosis. So the normal cells, they are able to repair themselves. That is the function. Then we have another four principles of radiation therapy. We call this is the 4 R's of radiation therapy, which is repair, redistribution, repopulation, and reoxygenation. So repair, it is a repair of the sublethal damage to the cells between fractions caused by the radiation therapy. Redistribution of cells into radioactive phases of the cell cycle. So we are redistributing the phases of the we are dividing the radiation into different phases so that we can redistribute the cell phases. So if we are acting today, the patient is undergoing radiotherapy, the cells will be in different state. If the patient is undergoing radiotherapy tomorrow, the different cells will be in different phase of the cell cycle. Then repopulation or regrowth of the cell between fractions, reoxygenation of hypoxic cell to make them more sensitive to the radiation. So fractionation, then this is how the principle of fractionation comes. So it is a treatment approach that takes the dose of radiation and divides it into equal fractions, recognizing that the dose may need to be higher owing to the plan of delivering multiple fractions. So the division of radiation dose over a period of time is done, which is usually 6 to 8 weeks. So in general, when we are as a gist, we can say that using the 4 principles, we are making use of fractionation. So fractionation of total radiation dose spares the normal tissue because repair of sublethal damage allows repopulation between the doses. The redistribution and reoxygenation that occur between the daily fraction increase the radiosensitivity of tumor, thereby improving the overall treatment outcome. Okay. Then there's another concept, that is radiosensitivity. So a radiosensitive tumor is the one that can be destroyed by the dose of radiation that still allows for repair and regeneration in the normal tissue. So the actively dividing cells, poorly differentiated cells, and oxygenated cells are more radiosensitive as compared to the otherwise, in contrast to the poorly highly differentiated cells and all. So these are some examples of the radiosensitive cells. So we have highly sensitive tumor, we can remember it as WELMS. So we have WELMS tumor, Ewing sarcoma, lymphoma, myeloma, and germinoma. So these are some examples of the highly radiosensitive cells. Then we have highly resistant, radio-resistant cells, which can be remembered as HOMP. So it is hepatoma, osteosarcoma, melanoma, and pancreatic carcinoma. So then using the principle of radiosensitivity, we can actually alter the radiosensitivity. So we have some this is called chemical modifiers of the radiation therapy. So we can use different type of agents to increase the effect of radiation therapy or to decrease the effects of radiation therapy. So radiosensitizer, these are the compounds that promote fixation of free radicals produced by the radiation damage at the molecule level. So the examples include pneumorazole, cisplatins, and mitomycin. The radioprotectants, these are the compounds that can protect oxygenated cells while having a limited effect on the hypoxic cells. So one example includes amifostin. In our setting, we are using the most common radiosensitizer that we are using is cisplatin. The common dose is 40 mg per meter square. And then we have temozolomide as well, which is used as 140 mg and 40 mg alternate days before food. So one day patient will get 140 mg and the next day it is 40 mg, like that. Okay, so as a gist, we are done with the first part. So radiation therapy, the aim of the therapy is to deliver a precisely measured dose of radiation to a defined tumor volume with as little damage as possible to the surrounding healthy tissue, resulting in eradication of tumor, high quality of life, and prolongation of the survival of patient. So the goals of radiation therapy, as we know, it includes it can be used for cure, control, and palliation. So approximately 60% of the cancer patient will receive radiation therapy at some point in their life, in their disease trajectory. So there are some tumors which can be treated by only the radiation alone. So which includes early stage Hodgkin's lymphoma, skin cancer, recurrent breast cancer. And when we talk about the palliative radiation therapy, so it can be used for multiple purposes, which can be for the relief of pain, prevention of pathological fracture as in multiple myeloma. It can be used for hemorrhagic obstruction. It can be used for ulceration. It can be used for superior vena cava syndrome. Okay, then there's another concept called anticipatory palliation, which seeks to treat the potential symptoms, lesions, before they actually become problematic. In this case, also we can use radiation therapy. Okay. So the second part is radiation treatment planning. So we are planning the course of the treatment. So the treatment planning is a detailed and precise process that focuses on obtaining a series of radiographic studies to identify tumor types, size, and location. The key components are initial consultation, simulation, localization, planning, imaging, dosimetry, and establishing positioning of the patient. So the first step will be, before talking about the planning, so a little more about planning. So meticulous treatment planning in radiation oncology is paramount in successful administration of safe and effective care for individuals requiring therapeutic radiation. So first we'll talk about consultation. So family members should accompany the patient to help provide information. Then the history and physical examination will be taken. The need for radiation therapy will be assessed. Initiate patient and family education about the proposed treatment and potential side effects. This all will be discussed in the consultation process. And then the planning for the radiation therapy is taken further. So simulation will be done. Simulation is actually the duplication of the same radiation treatment process. In this, what we'll do, the radiographs will be obtained for the patients, and then we are first of all so we are taking the radiographs of the patient. For diagnosis also we are doing the radiograph. So what is the difference between the radiograph for radiation therapy and the radiograph for the simulation? So in this simulation we need to specify the positioning of the patient as well, because we are duplicating the same position at the time of radiation therapy. So the purpose of simulation is to duplicate the geometry and mechanics of radiation treatment machines. So the target volume is localized and defined by using X-rays, scans, and physical landmarks. So for that we need molds, we need some stabilizing markings, so that we are able to stabilize the patient. We know the same position of the patient in which the patient was lying down at the time of simulation, so that we can duplicate it at the time of actual procedure. And then we can actually mark with the markers and everything, so that it can be made possible. So in this figure, as you can see, the laser marks are also taken to help with the localization. Then the target volume is defined. So establishing the target volume, which is localization of the tumor and extent of it, is the first step in treatment planning process. So target volume, it is the size of the tumor and approximation to the surrounding critical organs at risk. So in actually what we have in a tumor, we have one thing as target organ. That is, for example, we have a breast, so we have the target organ as a breast. In that also we'll divide it into different volumes, and then we have organs at risk. So the local organs which can be at the risk. So like for breast cancer, we have heart, we have lungs as a organs at risk. So we need to keep that also in mind to protect those organs. Like that. So talking about the target organ, in target organ, first as we'll take the scans. So in the scans we'll define the tumor volume. We'll know what is the volume. So we have three type of volumes which are taken. So we have gross GTV, which is gross target volume. We have CTV, which is the clinical target volume. We have PTV, which is the planning target volume. So GTV, it is actually a visible, palpable, or imaging detectable tumor. So we'll define it. And then CTV, it is a clinical target volume. It is potential microscopic tumor spread which we can also call it as this is some micrometastasis which can be present. So usually we take it as a 1.5 to 2.5 margin we keep for the CTV. Then for PTV is a planning target volume. It accounts for the daily setup or uncertainties or the organ motion. So it is actually setup and geometrical errors we corrected via PTV, planning treatment volume. So for that we have actually what happens is for GTV we want the dose, whatever dose we are defining, we want the 98% of the dose of GTV to go 98% of the required planned dose to go to the GTV, which is gross target volume. Okay, then we have the immobilization devices which we are using for simulation, which we are using for the actual treatment process. So the immobilization devices, skin markings, lead blocks and laser lights are used to help in reproducibility of the position. The different immobilization devices used are arm boards, knee saddles, breast boards, belly boards and head fixation devices. So this is one example of the immobilization device. And another we have the head and neck orifice. This is the one which is made of thermoplastics. Then we have bed cradles. So then radiation treatment delivery, the actual delivery process. And this was about the planning. So we made the consultation, we have done the simulation, we have made the immobilization devices, then we are doing the actual treatment delivery. So the treatments are administered daily for 5 days a week for 2 to 8 weeks depending on the tumor. Teletherapy treatment takes only a few minutes of the actual radiation exposure and require approximately 10 minutes in the treatment room altogether. Periodic beams are taken to ensure the accuracy of the setup. We have different modalities which are teletherapy and brachytherapy. So we'll talk about these in detail. So teletherapy. So it makes use of a machine to deliver the ionizing radiation. As the name suggests, we are using the radiation outside the source from a distance. We are delivering ionizing radiation from outside the body. So we have conventional and conformal radiation therapy. We have two types of teletherapy. We have conventional teletherapy and we have conformal radiation therapy. Conventional, we have 2D CRT. 2D, in this we are planning the tumor volume in a 2D space, and then in 3D we are planning into the tumor as a 3D product. And then in IMRT we have intensity modulated radiation therapy. IGRT is image guided radiation therapy. We have SRS, which is stereotactic radiosurgery. So 2D, as I already told you, it is we are localizing the tumor as a 2D image, and then we are giving the radiation therapy. In 3D CRT, what we are using CT or MRI scans to create a 3D picture of the tumor, and then beams are precisely directed to the tumor, to avoid the radiating normal tissue. So then another type is IMRT, which is intensity modulated radiation therapy. So it is a highly sophisticated form of 3D CRT. We can call it as a type of 3D CRT. So radiation is broken down into many beamlets, and the intensity of each beamlet can be adjusted individually. So we are modulating the intensity of the radiation to the tumor. So we are in a tumor itself, we are dividing that maximum dose has to be given to this area and the minimum dose has to be given to that area. The higher dose of radiation delivered to the tumor while sparing more healthy surrounding tissue. In this way, we are protecting the normal tissue as well. So examples of IMRT includes head and neck cancer, which is to avoid spinal cord and salivary glands. So this is a conventional radiation therapy in which this is the IMRT. So in IMRT, you can see we have modulated the radiation therapy. Like the red one is the highest amount of radiation that we want to give, like that. Okay. Then we have IGRT, which is image guided. Excuse me, sorry. So it uses specifically designed linear accelerators with built-in imaging capabilities to improve the precision and accuracy of the radiation delivered. For tumors in the areas of body that move, such as part, such as lung and prostate. Okay, then we have another type of radiation therapy is teletherapy, which is stereotactic radiotherapy, or we can also call it as radiosurgery, and we are calling it gamma knife. So it was developed in 1949 to treat small targets in the brain that could not be surgically removed. Precisely focused beams of radiation to destroy certain tumors, sometimes in a single high dose treatment. So basically, in what happens in radiation therapy, to a very fixed tumor, we are giving very high dose of treatment to that tumor, particularly that tumor itself. So it is basically used for brain and spinal cords. This is one type of frame which is used in radiation therapy. So this is the frame which is used. So we are using Linacs also for providing stereotactic radiotherapy. So this is the type of frame which is used. And then we have another one, which is this one. So there is a helmet type helmet which is producing gamma rays. Then another type is we've talked about the teletherapy, then about the radiotherapy, brachytherapy. So brachytherapy involves placement of a radioactive source within or close to the tissues to be treated, such as the interstitial or intracavitary techniques used in the treatment of oral and gynecological cancer. So we are giving the radiation therapy. We are actually placing the radioactive source within or close to the tissues. So we know that tele means outside and from a distance, and brachytherapy in the close proximity we are providing. So it may be used alone or in combination with the external radiation chemotherapy or surgery. So the radioactive sources are placed within or close to the target volume. Interstitial brachytherapy. These sources can be placed directly into the tumor and surrounding tissue. The examples include prostate cancer. Intracavitary brachytherapy within the body cavity. The example include gynecological cancer. The mold brachytherapy. So we are providing on a surface, for example, ocular malignancy or skin cancers. So these are one examples of brachytherapy implants which can be used. So most common implants which are used are radium, cesium, palladium. This is a brachytherapy machine which we are using in our setting. So nowadays the radioactive substance which we are using is iridium-192. These are some examples of the applicators which are connected. So one end will be connected to this machine, and the other end will be connected to the patient's applicators. Then we have other specialized radiation therapy techniques which are coming up nowadays. So we have intraoperative radiation therapy. It is accomplished by surgically exposing the tumor bearing organ, excising the diseased portion, and then delivering a single high dose of radiation directly to the tumor bed. Other type is we have hypothermia. Heat is known to be cytotoxic, and hypothermia is known to be most effective during the S phase of the cycle when the radiation is least effective. So thereby we are increasing the effectiveness of the radiation therapy. Okay. So the pattern of the treatment will depend on the tumor type, the location, the stage, and the general health of the patient. And then we are doing the weekly review of the patient. The patients during the radiotherapy treatment is reviewed by the radiation oncologist, and the side effects of the radiotherapy are observed. We have a file which is made here in AIIMS. We have a file for the patients who are undergoing radiation therapy. So the patients will be, the records will be made in that, and the patients will be reviewed every week. So radiation therapy in AIIMS. So how are we going about? We have OPDs. Every Tuesdays and Friday we have radiotherapy, radiation oncology OPD. In this, the patient will come to the radiation oncologist. The planning for the radiation therapy will be done, that what type of radiation therapy we want to give and how much will be the dosage and everything. Then the planning will be started. So planning, what we'll start is we will the simulation will be done. The scans will be taken. If it is a 2D radiotherapy, we just need to take a X-ray. If it is a 3D CRT, then we need to take a CT scan. So we are having in the room number 33, we have teletherapy machines which is there, and another machine which is there in room number 38. In room number 33 we are giving the 2D teletherapy, and in 38 we are giving the 3D radiotherapy. then planning, which is done, the planning for X-ray planning, the 3D planning is done in the planning room, which is the room number 34, and 2D planning is done in room number 41. And then we have room number 40, which is the review room. So the planning will be done from the different rooms, and the patients will be given markings, and then the radiation treatment will be started. So according to the dosage and everything, the plan, the patient will be undergoing the radiation treatment delivery process. So what will happen, usually what happens is there will be, for example, the patient is having 60 grays over 60 fractions over 5 weeks. 30 fractions over 5 weeks. So that, like that, the patient will get. So usually what happens is, in a week the patient will get 5 radiation therapy a week. So Monday to Friday the patient will get radiation therapy, and Saturday Sunday will be off. Like that, the treatment will continue for 5 or 6 weeks as well. Then radiation dosage. So the dose delivery of the radiation includes 2 major components. The first component identifies the output of the treatment machines from a specified point in the beam to the specified target through a specific medium, and the other component is the dosing determines the actual absorbed dose, which is more important with us. So the lethal tumor dose is defined as a dose that will eradicate 95% of the tumor yet preserve the normal tissue. So the radiation dose is recorded as absorbed energy per unit mass, and the SI unit of this dose is gray, and previously we were using a rad as a radiation therapy dose unit, but nowadays we are using gray. So 1 gray is equal to 100 rads. Then dose response relationship. So there's a clear dose response relationship between the dose delivered and the response of the tumor to the radiation. So unfortunately, when we are increasing the radiation, if we are increasing the radiation, we are actually also increasing the normal tissue damage as well with increasing the radiation dose. So it can be overcome by using multiple modalities of the treatment. So then came the concepts of the therapeutic ratio. This will be cleared by using this graph. So this is a radiation dose graph. As we are increasing there is this dose. As we are increasing the radiation dosage, it is actually increasing the normal tissue response. It is actually increasing the tumor response, but is also increasing the normal tissue response. But so in radiation therapy, we need to manage this gap as well. So then the concept of different modalities came up. So therapeutic ratio, because ionizing radiation does not differentiate between normal cell, it damages both. Therefore, achieving the therapeutic ratio requires a delicate balance between the desired treatment outcomes and the toxicity. So combined modalities are used. Different type of modalities like radiation brachytherapy we are giving, then we are doing chemotherapy and surgery, which is planned. Then this was about the second part. Then we'll talk about the third part of the radiation therapy. The third part will be side effects of the radiation therapy, its management and nursing management. The different side effects of radiation therapy include, we actually divide the side effects into early and late. So the early side effects include fatigue, nausea and vomiting, diarrhea, anorexia, dermatitis, dysphagia, mucositis and alopecia. The late side effects include xerostomia, fibrosis, decreased libido, infertility and secondary malignancy. So we'll talk about first we'll talk about the general nursing management, and then we'll talk about each side effect in detail. We'll talk about the side effect, the grading, the management and the nursing management for each side effect. So role of radiation therapy nurse in general. Radiation therapy nurses are primarily responsible for teaching, assessing and managing toxicities and supporting patients through a course of irradiation. Involvement of radiation therapy nurses in patient teaching is pivotal in patient outcomes. So patient education should include an overview of the treatment plan, address any myths and misconceptions, information about actual treatment, expected side effects of the treatment and symptom management. So pre-procedure, the patient preparation should be done, education, assess the nutritional status of the patient as the patient might have side effects later on. Informed written consent should be taken, educate the patient regarding the procedure and what to expect in the post-procedure period. Consider the need to be kept NPU, the need to comply with the specific breathing instructions. During the procedure, ensure the patient is focused the particular target tissue only. Radiation is focused on the particular target tissue only. Monitor for side effects, that is skin changes, blanching, erythema, desquamation, sloughing or hemorrhage, ulceration of mucous membrane, nausea, vomiting, diarrhea and GI bleed. Then post-procedure, assess the patient for any complication, assess any side effects and manage accordingly. So then we'll talk about specifically each side effect. So fatigue, for fatigue, it is actually a distressing, persistent, subjective sense of emotional, physical and or tiredness or exhaustion related to the cancer or cancer treatment that is not proportional to recent activity and interferes with the usual functioning. This was given this definition was given by NCCN. So for fatigue, the nursing management will be, we have to take the fatigue history. Routine assessment of fatigue should be done, set priorities and realistic expectations, schedule activities for peak times of peak energy, exercise programs should be initiated, reassure that fatigue is to be expected and it is not an indicator of disease progression. Other strategies to treat fatigue includes modification of drug regime, correction of metabolic abnormalities and pharmacological treatment of anemia, depression or insomnia. For anorexia, nausea, vomiting, diarrhea and weight loss, which is actually more specific to the type of radiation therapy, where the site of radiation therapy where it is given. For example, if it is in the abdominal area, the nausea, vomiting, diarrhea will be there and weight loss can be there. So a well-known important aspect of physical well-being is the ability to eat and have a good appetite. So head and neck patients experience changes in their oral cavity, lung patients may experience esophagitis, or gynecological patients experience nausea, vomiting and diarrhea. So for the nursing management of nausea, vomiting, anorexia, diarrhea and weight loss is, we have to control the nausea and vomiting by using antiemetics. Initiation of nutritional support should begin with immediately to ensure oral intake as well as replacing calories that may be lacking diet. Prophylactic NG feeding or gastrostomy feeding may be initiated and low residue diet may be initiated for diarrhea. And then we have radiation dermatitis. So radiation dermatitis is a skin reaction that is caused by radiation to the skin tissues. Skin reactions that are high in case of electron therapy as compared to the photons. So why it is high? Because photons have a tendency of, have a property of skin sparing, because photons go deep into the tissue without affecting the superficial layers of the skin. So we have a morbidity criteria of RTOG morbidity grading. So grade 0 means no change over baseline. Grade 1 is follicular or faint or dull erythema, dry desquamation. Grade 2 is tender or bright erythema, moist desquamation is there. Grade 3 is confluent, moist desquamation. Grade 4 is ulceration, hemorrhage, necrosis. So this is how the radiation dermatitis grading will be done. Radiation dermatitis nursing management. So we have to assess skin reaction, teaching skin care and managing skin breakdown if it occurs. Major teaching points should include the following: gentle skin washing with lukewarm water and mild soap in the treatment field. Avoid sharp razors, wear sunblock products and wear loose natural fiber clothing. Also, we have to educate the patient to use hydrophilic moisturizer, avoid any heating pads and ice packs on the treated area. But we can tell the patient that cool saline compress can be used. Analgesics can be given for pain. Surgical debridement can be done if it is grade 3 or 4. Then skin grafts and prevent secondary infection. For prevention of secondary infection, we can start with the antibiotics. So there is this research inputs, instruments to evaluate self-management of radiation dermatitis in patients with breast cancer. So a search was conducted of published literature from 2001 to 2018 that included patients who had received radiation therapy for breast cancer. 11 instruments were identified and evaluated for assessing self-management. One instrument was identified that measured a patient's ability to self-manage symptoms. The patient reported outcomes, measurement information system, efficiency for managing chronic conditions, managed symptoms should be considered for clinical integration. So this was a type of tool which was identified as to be good which the name of the tool is Patient Reported Outcomes Measurement Information System. So it is a self-efficacy for managing chronic conditions items. It comprises of 5 domains for self-efficacy for managing the daily activities, symptoms, medication treatment, emotions, and social interactions. So for this, the symptoms domain was taken for this aspect, was considered to be better. So the next side effect is oral mucositis. It is the inflammation of mucous membrane of the mouth, is referred to as oral mucositis or stomatitis. The symptoms generally begin as generalized oral discomfort and progress to extreme pain when eating, swallowing, speaking, and sleeping. Bleeding may be present and tissue necrosis may become life-threatening. So the RTOG criteria includes 0 means no change over baseline. 1 is patient may experience mild pain not requiring analgesic. There can, in grade 2, there is patchy mucositis that may produce inflammatory serous discharge. The patient may experience moderate pain requiring analgesia. Grade 3, severe pain requiring narcotic. Grade 3 is ulceration, hemorrhage, necrosis. Then the nursing management for oral mucositis. Prior to the initiation of RT, the patient should have a dental, speech, and physical therapy consults. Mouth rinses should begin at the first day of the treatment, and analgesics using WHO ladder can be used. So we are using actually triple gargle, which includes 2% xylocaine viscous, diphenhydramine, and soda bicarb powder. The patient can also be advised to take sucking ice chips. Then soft and liquid diet should be taken. Soft toothbrush should be used. A chlorhexidine mouthwash can be done, and then BG paint is also advised, so which includes 30 ml boroglycerin, 2 tabs of metrogel, 2 tabs of clotrimazole, and 2 tabs of tetracycline. These all are mixed and applied to the mucositis area. Other side effect is xerostomia. So it is actually due to damage of the salivary glands. The management includes meticulous oral hygiene, frequent sips of the water, sugar-free gums and candies can be taken, ice chips can be used, salivary substitutes like pilocarpine can be used, which is 5 mg per oral TDS. Commercial mouthwashes should be avoided. Then alopecia. So for that it should educate the patient to avoid too much combing or brushing your hair. Wash scalp with warm water only. Pat dry with a soft towel. Avoid frequent shampooing. Use a mild shampoo. Protect scalp from heat, cold, and wind by covering with scarf or hat or wigs. Avoid hairspray, hair dryers, electric curlers, and hair coloring. For infertility, the long-term side effect is infertility. Sperm or embryo banking before radiotherapy can be advised. Shielding testicles or ovaries during the radiation therapy if possible. Then assisted reproductive techniques can be implemented by the patients. Then regarding patient and family teaching, so we should educate the patient to wash the skin marked as radiation site only with plain water, and do not apply soap, deodorant, lotions, medications, perfume, or any talcum powder. So, and also we tell the patient, do not wash off the treatment marks, do not rub, scratch, or scrub the treated skin area, which can increase the irritation. Apply neither hot or cold to the heat or cold to the treatment site. Wear loose, soft clothing over the treated area. Cover skin with protected clothing during the treatment. Once radiation is discontinued, use sun-blocking agents with SPF factor at least 15 for the minimum 1 year. Then there's this research input regarding outcomes evaluation of weekly nurse practitioner managed symptom management clinic for patients with head and neck cancer treated with chemoradiotherapy. So the purpose was to determine whether improved monitoring through close follow-up with the nurse practitioner could enhance the treatment compliance and decrease the frequency of hospitalization. So it was a retrospective chart review. 151 patients aged 45 to 65 years diagnosed with stage 3 and or 4 oropharyngeal cancers were included. The two groups were divided. So one group was pre-chemotherapy clinic group and a weekly nurse practitioner led clinic group. So the findings include the average number of visits were 3 in the traditional treatment, whereas it was 6 in the nurse practitioner led clinic. The hospitalization rates were 28 in traditional treatment as compared to 12% which was in the nurse practitioner-led clinic. The chemotherapy dose deviations was 48% in traditional treatment and which decreased to 6% in the nurse practitioner-led clinic. So the study concluded that a weekly nurse practitioner-led symptom management clinic reduces rates of hospitalization and chemotherapy dose deviations and increases chemotherapy completion in patients receiving intensive chemoradiotherapy for oropharyngeal cancer. Then we are done with the third part. Now we'll talk about the fourth part, which is radiation safety. So first concept is radiation unit designing. So during the time of hospital designing, we need to keep the concept in mind. So the radiation unit designing should be done appropriately so as to minimize the radiation hazard. So this type of the image that you can see on your screen is a type of maze pattern. So as we know, the radiation travels in a straight line. So what we do, how do we design is, when you visit our radiation oncology unit also, you will see. So it is never in a direct, when you open a gate, there won't be direct the radiation source. So we'll divide it into different maze patterns so that the radiation which comes after traveling a long distance, the radiation output will be very less. And then there's another concept which is last man out switch. So only the last person which is coming out of the radiation unit should ensure that all the person are out, and once the gate will be closed, then only the radiation will be delivered. Otherwise the radiation won't deliver to the patient. Then there is lead shielding should be done. Lead lined glass windows are there. Then we have lead lined plastic board. Then we can label outside that this is the radiation sources there inside, so do not enter. Like that we can do. Then we have another principle which is ALARA, we call, which is as low as reasonably achievable. So we have to minimize the dosage, the exposure to us. So we have to keep the 6 feet distance. We have to minimize the exposure less than 30 minutes. We should use the radioactive like shieldings, which is lead aprons we can use. And then we have these dosimeter badges which are given to the workers which are working in that area. And then dosimeter badges are checked every year for the amount of radiation the person has been exposed to. Okay, then we have to, regarding the radiation safety, we have to also protect the caregivers, because if a patient is, nowadays we are not using a radioactive substances for home care, but still we need to keep this thing in mind. If the patient is having a implanted radioactive substance, so we have to educate the caregivers as well. So for that we need to educate the patient, minimize the time spent in close proximity to the patient, maximize the distance from the radioactive material. When possible, use shielding to decrease exposure to the radiation. In case of a patient has non-sealed radioactive, so the patient is instructed to flush the toilet 2 to 3 times after use, and patient is log rolled to prevent displacement of any intracavitary delivery device. There is research input regarding so radiation therapy survivorship, healthcare providers' perspective on health education and care. This study was designed to identify priorities for improvement in radiation therapy, which is specific to cancer survivorship education. So an online survey of healthcare provider communication with patients regarding survivorship was administered with an academic radiation therapy oncology practice. 17 survivorship categories were evaluated for each provider, including when and how often the survivorship issues were addressed, perceiving priority of the issues, and provider knowledge of survivorship resources. So 23 providers responded, and provider reported that 5 most important patient concerns were fear of recurrence, the radiation therapy side effects, surveillance, preventive measures, and nutrition and stress management. The most time was spent discussing the side effects and recurrence risk. So to conclude, the nurse's role in radiation therapy is multifaceted. Role components include patient assessment, patient education, support and counseling, physical care and continuity of care, research and administrative and leadership activities. To effectively care for the patient prior to, during, and at the completion of external radiation therapy, the nurse must know the physical and biological basics of external radiation and its clinical application. So today we discussed about the different, so we divided into the 4 aspects. So we discussed about the basic concepts, the biological effects, the uses of radiation therapy, the principles, the types of radiation therapy, the treatment delivery process, the planning, consultation, simulation, the side effects, its management and nursing management, and then we talked about the radiation safety. So thank you. If you have any doubts, you can ask me. कमेंट्स कहाँ दिखते हैं?